Hello, this is Professor Tiam. Today's lecture is about how to apply the nursing process to patients with problems of self-concept. This is Unit 6, Module 1, and we're focusing on self-concept, how people see and value themselves. You'll want to read Treese, Chapter 9, pages 238 to 250. We'll cover 6 key points today. The 4 components of self-concept, identify body, self-esteem, and role performance. How self-concept connects to developmental stages. We'll talk about Erickson's developmental stages, common stressors and coping strategies, how nursing actions can build or harm self-esteem, evidence-based care for issues like body image changes or role conflict, and finally, how to apply the nursing process to support a patient's self-concept in clinical. Keep in mind, the goal is always to help patients feel confident and valued, even when they're facing major changes. When we talk about self-concept, we're talking about a person's overall understanding of who they are. It gives them a sense of meaning, stability, and confidence. How someone thinks about themselves, their self-concept, shapes how they feel about themselves, which is their self-esteem. Self-concept isn't something that stays the same. It changes over time and with experience. We call this the dynamic self. It evolves as people face new roles, challenges, or changes in health. There are 4 main components you'll need to understand. First, we have personal identity, body image, self-esteem, and role performance. Personal identity is how a person defines themselves as unique. For example, a patient saying, "I'm a retired railroad engineer," is expressing their identity, the qualities and experiences that make them who they are. Second is self-esteem. This reflects how much a person values and accepts themselves. Low self-esteem can make a person more vulnerable to stress or crises, like when someone experiences repeated failures such as unsuccessful fertility treatments. Third, we have body image. This is how a person views and feels about their physical appearance and abilities. Health changes like facial injuries, burns, or the need for a walker can strongly affect body image and how someone relates to others. And finally, we have role performance. This is about how people carry out the roles that are important to them, like being a student, a parent, or caregiver. When these roles start to compete or feel overwhelming, role strain or role conflict can occur. Together, these 4 components, identity, self-esteem, body image, and role performance, form the foundation of self-concept. As nurses, we need to recognize how illness or stress can affect each one so we can support our patients holistically. When we talk about personal identity, we're referring to how you see yourselves as a unique individual, someone separate from others. This is how you view yourself as a unique being separate from others. Personal identity is what makes you you. It's shaped by your name, background, values, and life experiences. It defines what makes each person distinct from everyone else. It develops over time, beginning in childhood. Our sense of identity forms early through family, culture, and social experiences, and it continues to grow as we mature and take on new roles. It's relatively constant and consistent, but adolescents are much more vulnerable to identity changes. That's because adolescence is the time when people start asking questions like, "Who am I and where do I fit in?" making the stage especially important for developing a healthy sense of self. A strong identity gives people meaning and confidence. They can appreciate other strengths while still valuing their own. But when identity is weak, people may struggle to set boundaries or let others define who they are. As nurses, it's important to recognize when a patient's sense of identity might be challenged. For example, after a life change or loss of independence or illness, asking questions like, "How would you describe yourself to others?" or How can you describe who you are can help patients reconnect with that part of themselves. Self-esteem. This is simply how a person likes themselves or feels about themselves. It's the emotional reflection of self-concept. In other words, how we think about ourselves affects how we feel about ourselves. Self-esteem is often thought of as the difference between the ideal self and the real self, what we wish we were versus who we believe we actually are. When the gap between those two feel wide, people often experience low self-esteem. When they're more aligned, self-esteem tends to be healthier. Now, the overlap you see in this diagram, that space between the ideal self and the real self is where self-esteem lives. When assessing self-esteem, I like to ask open-ended questions such as, how do you feel about yourself? What do you like about yourself? If you could change one thing about yourself, what would it be? These questions help us understand how the patient perceives themselves and whether they're being realistic or overly critical. Low self-esteem can be seen in both what patients say and what we observe. So examples of objective data might include hesitant or halting speech, poor posture, slumped posture, avoiding eye contact as well. Subjective data might sound like I can't do anything right or I always mess things up. When a patient expresses disappointment or self-doubt, avoid jumping in with quick reassurance. Saying something like, oh, don't feel that way, that might invalidate their feelings. Instead, listen, validate, and use therapeutic communication. Let them process what they're expressing first. Let's use the movie Barbie to illustrate two extremes of self-esteem. So here we have Barbie and Ken. So in this movie, Barbie represents very high self-esteem. She's confident, capable, and secure in who she is. Ken, on the other hand, struggles with low self-esteem. His worth depends entirely on Barbie's attention and validation. So let's start with high self-esteem. When someone has high self-esteem, they tend to give themselves positive feedback. They express feelings of being capable, worthwhile, and competent. Their mindset sounds like being successful one time means I can do it again. This confidence allows them to handle challenges without falling apart. Self-esteem is often connected to how people evaluate their own effectiveness, how well they feel they're doing at work or at school, in their family, or in social situations. So when those areas feel balanced and successful, self-esteem tends to stay high. In contrast, low self-esteem sounds different. These individuals often give themselves a lot of negative feedback. They might avoid eye contact or seem overly critical of others. They have low motivation to learn or try new things. They're quick to focus on failures instead of progress. So as nurses, it's important that we recognize both ends of this spectrum. So not just through what the patients say, but also through what we see, our observance of our patients. Whether a person feels like Barbie or Ken on a given day can directly affect their health behaviors, their motivation, and their recovery. So here, the ideal self versus the real self. You see the expectations versus the current skills, their aspirations versus their attributes, what I ought to be versus their successes, what I wish I were and what I really am. So it's that area in between these two columns that makes up a person's self-esteem. Now let's talk about body image. Body image is the mental picture of your physical self, including both appearance and how your body functions. When we talk about body image, it's not just about looks. We're also talking about mobility, energy, strength, and independence. When those things change, even temporarily, people's sense of self can shift also. So what are some factors that affect body image and how might that impact health? For example, sudden illness or trauma, like sustaining facial fractures, or needing a new wheelchair or crutches can dramatically affect how someone sees themselves. So you might come across many patients who say things like, I don't even recognize myself anymore. Um, for example, those words reflect body image disruption. Body image is also influenced by family, culture, social norms, and education. So basically everything that shapes how we understand beauty and ability. Some cultures value thinness, others value strength or fullness. So these messages start early and stay with us through life. When you're assessing body image, you might ask, when you look in the mirror, what do you see? How do you think others see you? Or how has your ability to do things you enjoy changed since your illness or injury? As nurses, we need to remember that the closer a person's ideal body image matches their perceived reality, the healthier their body image tends to be. When there's a gap between what they wish they looked like and what they see, that's when body image issues and even depression can emerge. So we know that body image strongly affects those that are in their adolescent phase of life. Role performance. This is about the actions and behaviors a person takes to fulfill their roles in life. Each of us plays multiple roles: student, caregiver, partner, parent, employee, etc. So when everything aligns, those roles give us a strong sense of purpose and identity. Sometimes these roles come into conflict. So there's three common types you'll encounter in nursing care. So role strain happens when someone feels inadequate or overwhelmed by the expectations of a role. So a parent or of a newborn who feels they're failing as a caregiver, or like in this picture, a nursing student who thought they'd sail through the program but now feels exhausted and behind. That's an example of role strain. It's the mismatch between what you expected of yourself and what's actually happening. Next, we have interpersonal role conflict. This is when your idea of how to perform a role clashes with someone else's expectations. So perhaps a student might have an approach to patient care that they believe is true, but maybe their clinical instructor expects something completely different. So that tension is called interpersonal role conflict. And then there's the inter-role conflict. So when two or more roles compete with each other, so like a single parent, maybe whose child gets sick or has constant tantrums, and you have to miss a week of classes and possibly work. So you're trying to fulfill both roles as a parent and as a student, but you're pulled in opposite directions. So that's called inter-role conflict. These types of conflicts can cause stress, it can lower self-esteem, and it disrupts self-concept because you start to question, are you doing enough? Am I failing at everything? When planning care for patients, especially those struggling with caregiving duties or multiple responsibilities, it's important to assess which roles are in conflict and how these conflicts are affecting their well-being. So questions like, what are your 3 or 4 major roles in life? How successful do you feel in each role? What's interfering with your ability to manage your roles? These simple questions help patients reflect and regain perspective. Development of self is a complex, lifelong process. Erik Erikson's theory emphasizes developmental tasks relevant to self-concept. His psychosocial theory of development is helpful in understanding key tasks that people face at different stages of development that can affect their formation of self-concept and how to maintain self-concept. So at each stage, a person faces a certain conflict, and as a result, they can develop a particular quality or skill. So, for example, we have trust versus mistrust in the infancy years. So, the first year of life, the infant is challenged with the development of sense that the world is a safe place. Then we have, autonomy versus shame and doubt in the toddler years. So their developmental task is to realize oneself as an independent person who can make decisions. The 3 to 6 year old, so that's the preschool years, that stage is called initiative versus guilt. So to develop the ability to try new things and to handle failures, and so on. So these are important stages that you should remember, and you will need to memorize all of these 8 stages. The nurse must consider the patient's stage of development. So self-concept develops and changes across the entire lifespan, as we see starting in infancy. Self-esteem tends to be highest during childhood. This is when children are learning how to be autonomous. They're learning how to become independent and function in the world. So they gain a lot of praise for learning and trying and accomplishing tasks. And they receive positive reinforcement from parents, teachers, and maybe their peers, which helps them build a strong sense of competence and self-worth. So as adolescence begins, self-esteem may decline temporarily as they become more self-aware. They might compare themselves to others, and they might seek their peers for approval. So we see that in older adults, self-concept may be challenged by the loss of roles or physical decline. So at the end of the list, we see integrity versus despair in the age of 60 and older. So the developmental challenge, the task is challenge is to view one's life as satisfactory. Stressor is a real or perceived change that threatens body image, identity, and role performance, and essentially one's view of self-concept. So the most important influence on a person's ability to cope with a major stressor is their perception of the stressor. So in this diagram, each corner represents a part of self-concept that can be affected by stressors. So let's see, we have body image, including physical health and visible appearances affected after having a stroke, maybe getting a colostomy bag. There's obesity, amputation, facial trauma, pregnancies, or even aging. So these affect how people can see themselves physically and how they function day to day. So identity stressors come from major life events, so a job loss, a divorce, repeated failures, or changes in sexuality or dependency challenge a person's sense of who they are. Role performance stressors happen when people struggle to balance roles or meet expectations. So caring for aging parents, work stress, maybe losing a job, parenting changes like empty nest syndrome. These stressors make people feel like they're not living up to their responsibilities. So all these stressors, whether it's physical, emotional, situational, etc., it can alter a person's self-concept or self-esteem. So again, the most important factor in how someone copes isn't the stressor itself, it's the perception of the stressor. So our roles as nurses is to help patients reframe and rebuild their self-concept when life changes challenge their sense of overall self. Coping is the person's cognitive and behavioral effort to manage a stressor. So in other words, it's how people think about and respond to what's stressing them out. Everyone copes differently. Some people talk through their problems, others avoid them, and some turn to positive outlets like journaling or exercise. These are all coping mechanisms. So the most important factor, again, in how a person copes is their perception of the stressor, and this is actually evidence-based research that we talked about in class. It's not always the event itself that determines how stressful something is. It's how the person perceives it. So, for example, two patients could experience the same diagnosis, and one might see it as a challenge and start planning treatment, while another feels completely hopeless and defeated. So that perception drives everything about their coping process. And because perception shapes reality, it also determines whether people use positive or negative coping strategies. So a patient who sees a challenge as temporary might use problem solving, communication, or faith-based coping. But someone overwhelmed or hopeless might withdraw, avoid, or even lash out. So when assessing coping, the nurse should focus on the patient's subjective view, so their own interpretation of what's happening. So this is usually by what the patient is stating, because that's what determines how they'll respond. The type of stress, person's goals, self-concept, and self-esteem also play big roles in how they cope. So, for example, a person with strong self-esteem will say, I've handled tough things before, so I can handle this too. But someone with low self-esteem might feel powerless, which makes coping much harder. So in nursing care, this is where we apply it in real life. When patients struggle to cope, we often see psychological distress, like anxiety, for example. Anxiety might appear as a vague, uneasy feeling of dread or worry. Sometimes there's physical signs to anxiety. There's an increased heart rate, shallow breathing, or restlessness. So if you notice this, don't rush in with reassurance like you will be fine, that can invalidate a patient's feelings. So again, we use therapeutic communication. Say things like, you seem worried about something. Would it help to talk about it? So that opens the door for them to share what's really going on, and it helps you figure out what stressor they're perceiving. Stressors can come from roles, as we talked about earlier, so what people do and who they are to others. So role strain happens because someone feels inadequate or unsuited for a role, like a new parent who feels maybe clumsy or not adequate when caring for their newborn. So role strain role conflict happens when there's competing demands between many roles. So when you see this in your patient, your goal is to help them make constructive behavioral changes. So maybe they can state 2 positive actions they can do that can maybe better fulfill their responsibilities. So this is how we this is maybe our goal in care, and so we evaluate if they can successfully state and maybe perform these 2 positive actions. So a stressor is real or perceived changes that threatens a person's identity, body image, or role performance, and that's what we mentioned previously. We don't just treat the illness, but we help people reframe their stress, strengthen their coping mechanism, and restore their sense of self-concept and control. Maslow proposed that all individuals have a set of needs and motivations that drive their behavior. So these needs range from the most basic survival needs to higher level psychological and self-fulfillment needs. So according to Maslow, our basic needs must be met first. Food, water, shelter, and safety must be met before we can move on to the higher needs like belonging, esteem, and self-actualization. So our behavior is motivated by multiple needs at once, but we can't really fulfill each higher level until the lower ones are satisfied. So if we meet a patient as a nurse whose basic physiological or safety needs aren't met, that can interfere with their healing, their motivation, and even their feelings of self-concept. So at the top, we see that self-actualization is where a person reaches their full potential and feels truly fulfilled. So a self-actualized person tends to have a strong connection with reality. They see things as they are, not through fear or wishful thinking. Feel comfortable with themselves. They accept their strengths and flaws without guilt or shame. They stay focused on solving problems rather than being self-centered. Enjoy solitude and have a good sense of humor. They resist social pressure and they don't just follow the crowd. Importantly, they have a high sense of self regard. So that ties directly back to our topic at hand. So self concept and self esteem are highest at this peak. Understanding this hierarchy helps us identify where our patients are. So a patient struggling with pain or homelessness can't focus on self esteem or self growth. So the basic needs take priority first. Once those needs are met, that's when we can focus on helping them rebuild confidence, self-worth, and positive self-concept. So I remember something that my instructor told me a long time ago when I was in nursing school. He said that most people, or a very small percentage of the world, actually ever really meet the top peak of self-actualization in Maslow's hierarchy of needs. So I always thought that was really interesting, and thought it'd be a lifelong goal to try at least to attain that peak, that sense of um, high self-concept and enlightenment. A nurse's actions can affect a patient's self-concept and self-esteem. So self-awareness is very important. So this is the foundation of our nursing care. Before we can help patients feel whole, we must first understand our own emotions, attitudes, and comfort levels, especially when it comes to body image and self-concept. The first step as a nurse is always to examine our own biases and beliefs. For example, if you're about to assess a patient with a facial disfigurement or maybe a mastectomy site, take a moment to prepare yourself. The patient can easily pick up on discomfort or surprise, so staying calm, neutral, and compassionate helps the patient feel accepted. We promote self-esteem by encouraging independence, especially in activities of daily living or ADLs. Even small acts like brushing their own hair or washing their face gives patients a sense of control and dignity. It tells them you're capable, you still have worth. A healthy nurse-patient relationship helps patients focus on the positive aspects of their healing. So we can't always change the situation, but we can help them see meaning and progress in what they can do. So your attitude, your patience, tone, compassion has a direct effect on their self-concept. And finally, we use therapeutic communication. Avoid false reassurance or forced positivity. For instance, if a patient says, "I can't believe I look like this," don't say, "Oh, you'll be fine," or things like that. Instead, respond with, "Tell me what you mean by saying that you look this way." So this approach helps them open up and process their emotions safely. As nurses, providing evidence-based practice means integrating knowledge from the humanities, sciences, nursing research, and clinical experience. So a wide perspective lets us see patients as whole people and address self-concept issues meaningfully using evidence-based practice. So I looked up some of these topics that we're discussing today and did a search on recent publications regarding identity confusion, for example. So there are identity building curricula that school-based programs use to guide teens through identity exploration and resolution. So it seems as this has successfully increased the identity clarity, self-esteem, and grades in randomized studies. So they're culturally adapting versions of this program as well in the schools and it's been showing great success. Their body image, they've used in research psychoeducation and peer and cognitive dissonance approaches. So systematic reviews in youth show improved body appreciation and self-esteem. So in adults in cancer, these nurse-led psychosocial interventions reduced the body image distress and improved treatment adherence. So really interesting studies. Another one on low self-esteem. This study used structured psychological programs. They used digital as well as CBT, which is cognitive-based therapy. I'm sorry, cognitive behavioral therapy. So these meta-analysis finds that the interventions produce significant gains in adults' overall self-esteem, and these digital programs or mobile self-help apps also helps improve their self-esteem. I feel like there's a lot of different apps that are coming out now. One that comes into mind is BetterHelp, I believe that's called. So a lot of these seem to be currently in use, and research shows that it does help a lot. So role conflict or role strains. One research project used a solution-focused and resilient skills training. So there was a collaborative therapy that related nurse psychology programs to reduce role-related stress and enhance coping self-management in clinical settings, and I guess this was found to be effective. Process can specifically help patients with self-concept challenges. We want to keep the process going until the patient's self-concept is improved, restored, or maintained. It's not a one-time fix, and it may involve continuous care. First, we have assessment. Again, add PI, assessment, diagnosis, planning, implementation, and evaluation. So first, we want to assess and include not just what the patient says, but what they do. So there's the nonverbal cues of the halting speech, slumped posture, avoiding eye contact, for example, that reflect low self-esteem. We can also ask open-ended questions like, how do you feel about yourself? We want to create a safe environment when we're assessing. So we want to sit at eye level. We want to minimize interruptions and choose a quiet place. It shows respect and encourages the patient to share honestly. When intervening, we want to use empathy. So we don't dismiss and we don't reassure too quickly. So instead of saying, you'll be fine, say something like, you seem worried. Would you like to tell me more about how you're feeling? That opens the door to emotional processing. We want to evaluate by observing behavior changes. So are they participating in self-care, hygiene, or engaging in conversations? So these objective actions tell us whether their self-concept is improving. So for instance, resolution of a disturbed body image might be seen when a patient says, with my hair combed this way, the graft is less noticeable. So they may have had hair implants, for example. This shows adaptation and acceptance. The use of the nursing process is continuous until the patient's self-concept again is improved, restored, or maintained. Let's reiterate some of the things we said earlier about the nursing process when patients struggle with self-concept. So again, when we assess, we want to observe carefully. Their nonverbal behavior is a powerful clue. So halting, hesitant speech, slumped posture, avoidance of eye contact, and unkept appearance, excessive apologizing, these can all point to self-esteem issues. Like we said it before, sit at the eye level, provide a quiet space, and minimize distractions. This can create safety and trust so patients feel comfortable sharing. So diagnose, we use both our clinical judgment and the patient's own views. So common diagnoses include disturbed body image, situational low self-esteem, ineffective role performance. Those are common nursing diagnoses. Validate what you see by asking, how do you feel about yourself? What do you expect from your healthcare? What goals do you have? So planning. The patient must be part of setting their own goals. So we want to make them realistic, measurable, and aligned with the patient's values. We include inputs from significant others or support systems if appropriate. Implementation. So this is where the nurse-patient relationship matters most. So we want to encourage healthy coping, nutrition, rest, safe movement, stress reduction, promote independence, use therapeutic communication. We can possibly refer to physical therapy, occupational therapy, maybe behavioral health, or social services when needed. Always remain self-aware of your own biases so they don't interfere with care. Evaluation. We want to measure success by objective, positive change. So are they helping with their own self-care tasks willingly? Are they participating in social interaction? So are they using constructive language about themselves? So language and statements about self-acceptance and adaptation is what we want to hear. So progress is gradual in relation to self-concept issues, and small steps matter the most, and so we also want to motivate and encourage and always praise our patients for every small step along the way. So that wraps up our lecture on self-concept. So remember, every interaction you have as a nurse has the power to shape how a patient sees themselves. So speak healing words, act with empathy, and help your patients rebuild their confidence, one caring moment at a time. And remember, this also applies to yourself. So be kind to yourself as well.